Hi, I'm here with Dr. Gregory Piazza, board member and education chair at the North American Thrombosis Forum. We're here today to talk about the Atrial Fibrillation Action Initiative and with Dr. Piazza specifically speaking about comparison of novel oral anticoagulants. So thank you for joining us today. If you could please just give us a brief introduction and give us your clinical background as well for our audience.
Sure. Well, first of all, I want to thank you, Erica, for including me in this round of interviews. This Atrial Fibrillation Action Initiative is something that's very important to me because I'm a vascular medicine cardiologist and I see many patients every week who come in with atrial fibrillation and need to select a blood thinner to prevent stroke. And so, to put it another way, I have a lot of skin in the game when it comes to this action initiative. I am also a member of the board of directors for the North American Thrombosis Forum, and I'm the education chair. So because this action initiative is one of our major educational offerings over the next 2 years, this is also something that is very important to me.
Would you be able to give our audience an overview of the novel oral anticoagulants that are now used to prevent stroke and atrial fibrillation?
Of course. So we currently have 3 FDA-approved agents for stroke prevention and non-valvular atrial fibrillation. We have dabigatran, which was the first drug to reach the marketplace. It was evaluated in a trial called RELY, which compared 2 doses of dabigatran with the old standby of warfarin. The study showed that both doses were effective at preventing stroke in non-valvular atrial fibrillation. In particular, the 150 milligram twice daily dose was associated with a substantial reduction in stroke, and both of these doses were associated with a reduction in our most dreaded complication of anticoagulation, intracranial hemorrhage. Now, the 150 milligram twice daily dose was what was ultimately approved by the FDA. Shortly after that, we had the results of the ROCKET-AF trial, which evaluated rivaroxaban in comparison with warfarin for stroke prevention and non-valvular atrial fibrillation. Again, like what was found in the dabigatran study, this novel oral anticoagulant, rivaroxaban, was shown to be effective at prevention of stroke and non-valvular atrial fibrillation and also reduced the risk of bleeding. And based on this study, rivaroxaban was approved for our use in the U.S. Following that was apixaban, which was studied in the Aristotle trial. Aristotle trial was very important because it showed not just a reduction in stroke, but a reduction in major bleeding, and also a mortality benefit to the use of apixaban versus the use of warfarin for stroke prevention and atrial fibrillation. And apixaban was subsequently approved by the FDA based on the results of this trial. Now, we're waiting for Dr. Ruff, who's an important piece of the puzzle in this Atrial Fibrillation Action Initiative, to present the results of his ENGAGE trial, which is an enormous undertaking, looking at the efficacy and safety of edoxaban compared with warfarin for stroke prevention and atrial fibrillation. And in, I think, 2 weeks from now, we'll have those data back, and I'm really looking forward to seeing how edoxaban fits into the novel oral anticoagulant picture.
What would you say are the key differences in these agents?
So I think that the agents collectively have shown that they offer enhanced efficacy over the stroke prevention in warfarin, and they show improved safety. The differences between these agents are largely things such as how they're cleared from the body. Some of these agents are cleared almost exclusively by the kidney, and some of them have mixed clearance, and that has implications in our patients who may not have completely normal kidney function. How they're administered varies. Some of these agents are given twice daily, some are given once daily. That has some implications for medication adherence. And then they have different side effects. But I think as a class, they really have some important differences from warfarin, namely enhanced efficacy and improved safety.
What are some of the best practices in deciding on what novel oral anticoagulant to use when treating patients?
Well, I think there are several things to consider when you look at these novel oral anticoagulants. The first thing I consider is patient preference. It's fairly common in my clinic that patients will express their desire to not be on a drug that's just entered the marketplace. They want to know that the drug has been evaluated clinically for a couple of years before they take the drug. And so I'll often, for those patients, offer one of the novel oral anticoagulants that has been on the market for longer. Patient preference also has an important consideration for how often they have to take the medication. If medication adherence is going to present a difficulty, one of the once-daily drugs may be preferable. I always consider some of the side effects of the medications when I'm trying to pick the right drug for my patients. So in patients, for example, who have a lot of baseline gastrointestinal problems like dyspepsia or heartburn, I may not tend to pick dabigatran, which is associated with gastrointestinal discomfort, because it may just cloud the picture and lead to side effects, and then unfortunately lead to non-adherence. Similarly, patients who have poorly controlled headaches or bad migraines may not tolerate rivaroxaban as well, because rivaroxaban's been associated with increased incidence of headaches in a small group of patients. And it'd be hard to start a drug like that in a patient who already has headaches, because they may then attribute their headaches to the medication. So I try to select carefully based on side effects. And then finally, I look at the patient's overall bleeding risk. Apixaban had some favorable results when it came to major bleeding, and patients who may be a little bit more on the frail side when it comes to risk of bleeding, that might be a preferable agent.
Why is there now a surge of novel oral anticoagulants used in treatment for atrial fibrillation?
Well, I think that there are probably three major reasons for that. I think one is that the trials have really showed improved safety with these drugs. And I think that the medical community is looking to first do no harm, and the idea that these drugs provide good efficacy with improved safety is very attractive. The efficacy of these drugs is also an important consideration. Getting an additional reduction in the risk of stroke over warfarin is an important consideration. And then finally, we can't underestimate the ease of use of these medications. No longer do we have to have patients take their blood to have their INR checked every week or every couple of weeks. Patients have for a long time complained about the issue of food-drug interactions, not being able to eat green leafy vegetables as frequently as they'd like to. As cardiologists, I love when my patients eat green leafy vegetables, but when they're on warfarin, sometimes they're told that they have to have less of that or avoid green leafy vegetables. And with these novel agents, that's not really a consideration. And then also there's the issue of drug-drug interactions. It's fairly common that especially elderly patients will be started on an antibiotic for a urinary tract infection, and then the INR will skyrocket, and with that comes an increased risk of bleeding. With the novel oral anticoagulants, these drug-drug interactions are less frequent, and that is certainly another attractive feature.
Well, thank you again for taking the time to speak with me.
Well, thanks again for having me, and I look forward to the finished product.